to shut it off. So I've got the pleasure of introducing someone who's probably well known to most of you who are listening in, and that's Dr. Seyone, who is one of the province's leading neuropsychiatrists, the founding director of the ABI clinic at Toronto Western, and he remains on staff at UHN. He is generous with his time doing things like this. He also consults with a number of community-based brain injury organizations, including this one. Active in teaching on the faculty of U of T. He's won the prestigious Ivan Silver Award for excellence in mental health education. He also does medical legal work, and I had the pleasure of cross-examining Dr. Seyone in the courtroom. He's one of the most fair-minded medical experts around. In that case, he was retained by the defense, but his opinion was so fair that I actually called him to the courtroom to testify for my client. He calls it like it is, which is what we want in experts. So Dr. Seyone, all yours.
Well, thank you very much, Troy. And thank you to Melissa and BIST for inviting me to do this presentation. And thank you to Dr. Adhd as well. I don't see him here, but I presume that he's somewhere. I was asked to talk a little bit about psychopharmacology and brain injuries. I've done this talk before, so if you have attended this talk, my apologies if it's a repeat of what I've done before. But I never talk from a piece of paper, so I say what comes into my head. So it's never going to be exactly the same as what I talk about, even if I've done it before. So you will find that I kind of digress at times to talk about different things as well. Anyway, let me put my slide up, and then you can probably see it. Oh, sorry. Okay. Where did I?
While you're putting up your slides, Dr. Seyone, I also want to just let participants know, as Melissa mentioned, you can ask questions throughout by typing. If typing's an issue for you, you're also welcome just to raise your hand, and then Melissa or I will unmute you and you can ask your question directly. So we want to just make sure that Dr. Seyone's as accessible as he can be to everyone who's participating tonight.
All right. I hope everybody can see my slides now. I'm just going to put it there. What's happening? Okay. Can people see my slides? Okay. Now I'm basically talking to a screen. I usually like to do the talking, but I can actually see people I'm talking to. But so if I'm going completely off topic and talking about something that doesn't make any sense whatsoever, please let me know, so I can actually kind of try and get back on point. So essentially, I mean, I was asked to talk about medications. So basically how medications can be used in the treatment of patients who have had a brain injury. Now, why are we going to talk about medications? Because a couple of things. One is that I've been doing this for about almost 25, 30 years now, and my patients now are a lot more complex than what patients were even 15 years ago. 15 years ago, patients who didn't survive some of the most serious injuries. So 15, 20 years ago, patients usually, I mean, if they had a severe brain injury, they might have actually kind of died on scene, or they are in institutions or something along those lines, because they really didn't kind of have that much of a quality of life afterwards. But now what's happening is neurosurgery, neurology, all of these other medical specialties have kind of advanced enough where patients are actually surviving even more serious injuries. So patients are surviving brain injuries, like with half their brain kind of damaged in some ways. And these patients are surviving to the extent where they're actually being discharged from hospitals and they're actually going back to live with their parents or live with somebody else. But the problem when you have such severe brain injuries is that the chances of these patients having severe behavioral issues or depression or anxieties or inability to get back to doing any form of kind of worthwhile activities goes up exponentially. So when it goes up, I mean, somebody who's extraordinarily violent, let's say, who's living in the community with elderly parents, how do we manage these people? How do we actually kind of control these people to the extent where they have some quality of life, while at the same time, the family doesn't get burnt out? I mean, and often these families do get burnt out because it's not like having, let's say, children. If you can imagine, all of us, I mean, at least most of us have had children, and we are able to cope with the kids because the kids do grow up and at some point they become independent. And so we can actually end up, okay, getting a little bit more time to ourselves. But patients who have got brain injuries do not generally get better to the point where they can be independent. So you're basically looking after that particular patient, can be for 5 years, 10 years, 15 years, 20 years. So at the end of that, you're completely burnt out. And if the person is aggressive or severely depressed or anxious or has obsessive compulsive problems, they end up finding that they have a lot of difficulties. So that's why you need medication sometimes just to manage these patients. Now, I'm going to talk a little bit about brain injury itself, because if I talk about just medications in abstract, it's not going to make any sense whatsoever. So I'm going to try and talk a little bit about why you're actually using these medications, and then what type of medications you're going to also then use. So what is brain injuries? Brain injuries are dynamic. It's not static. So patients don't get one type of brain injury and they end up having the same problem indefinitely. Their problems change over time. So it could be initially, and often these patients present with medical issues, because that's what the most common thing is. So they might have weakness on one side, or they might end up having aphasia where they can't talk very well, or they might have some other medical issue, which becomes, for the first year or two, that's the most important things that needs to be addressed. Second year of the injury, third year of the injury, then it becomes that you're now dealing with more of the psychiatric problems that happen. And that's when you get the multidimensional nature of these type of injuries, where depending on whether patients have focal injuries or diffuse axonal injuries, or a microvascular injury with loss of autoregulation, or kind of other types of damage to the brain, now you end up with some of the psychiatric things happen. Most of you know what coup contra coup injuries are, and basically this is in brain injury that happen in accidents or falls, where the brain, if you can imagine, is suspended in a liquid inside our skull. It's actually not attached for most of the area except for the bottom bit where the brainstem goes down into the spinal cord. So this brain can theoretically move. So if you actually kind of whack your brain on the windshield or something like that, and then kind of bounce back and kind of bounce off the back of the chair or something, your brain also equally well is moving back and forth. And that leads to damage, not just to one area of the brain, but also the opposite area of the brain. So in this particular picture, there's damage to the back end of the brain, the occipital lobes, and then to the frontal lobes as well. But along with this, there's also a rotational force, and that rotational force also causes damage to the brain as well. And then these different mechanisms causes significant neuropsychiatric problem, which is not necessarily focalized. It's not like somebody hits you on the head with a hammer and you have a damage to one particular area. These type of injuries often lead to a diffuse problem, like a diffuse axonal injury, that then leads to all sorts of neuropsychiatric problems. So our brain is divided into different areas. So it actually kind of does different things. For example, I mean, the front part of the brain is the one that's most important for what we are talking about in terms of some of the behavioral issues that become more prominent in patients who have brain injuries, because this is where we do decision-making, organization, planning, appreciation of what life is all about, and judgment. So this is where, if you damage this, you can damage all of these different areas. Whereas if you actually damage the parietal lobes or the side part of the brain, this is where we get problems with language, with problems with like movements on the right or the left side, problems with kind of speech. So you can get these type of issues if you damage the left or the right parietal lobes. Then if you now go into the deeper parts, kind of, and the bottom parts, that's where the consciousness lies. So these are the areas where you can end up with patients who become vegetative. So some people who might get damage to the basal area of the brain end up never leaving hospital because they never regain consciousness. But other types of things also get damaged in these areas, like emotions. So patients who become very depressed or very anxious. What about appetite? Some patients have less appetite. Some patients actually become severely increased appetite, and there's a syndrome called Kluver-Bucy syndrome where patients continue to eat, and they can actually put on significant amounts of weight. But these are all depending on where the damage is. But don't forget the fact that I mentioned that even in a focal damage, you also still get some of the rotational and some of the kind of bouncing around. So you get generalized damage as well. So you can have front part of the brain being damaged, but you also can have problems with the emotions, because even though they're in two different areas. So that's why patients who are kind of behaviorally abnormal can also have depression or anxiety as well. So having said all this, what are the different type of psychiatric problems that can happen in these patients? when I teach some of my students, I always ask them to tell me in one word, what is the psychiatric problem that can happen, all the different psychiatric problems. And everybody looks at me as if I'm completely off the wall and say, okay, how can I tell you all the different problems when there's kind of all these different things happen? Yeah, so the answer basically is anything. Any type of psychotic problem you can think about can happen in people with brain injuries. The only thing that you will find different is that you won't call it schizophrenia. You won't call it a schizoaffective disorder. But having said that, you can actually get psychotic illnesses that are triggered by brain injuries. So you get the immediate problems like post-traumatic delirium or post-concussive syndrome. This is what everybody talks about in minimal brain injuries or minor brain injuries. Everybody has concussions and post-concussive syndromes, which causes all sorts of issues. In a small but significant percentage of patients, they end up having severe problems that sometimes are even worse than patients who have bigger damages. Then you have the cognitive difficulties. What are the affective disorders? Affective means mood. So these are all the different mood disorders, the anxiety disorders, the psychotic disorders, as I mentioned. A lot of these patients have sleep disorders, and a lot of these times the sleep is actually disturbed, which then also leads to all these other different problems as well. Personality changes that happen, and behavioral sequelae, which is the hallmark of why we need to sometimes give medication to these patients, because if somebody is extremely aggressive, we need to do something about it. The opposite of aggression is apathy, which also, in my opinion, is a form of aggression. In the sense that if somebody is sitting there, and like, let's say, assume that this is your spouse or somebody who's very close to you, and this was a very active, social, enterprising person. And now after the brain injury, this person is just sitting there and staring off at the wall, not even watching television, but staring at the wall or the ceiling and doing absolutely nothing. Day in, day out, they're doing nothing. How aggressive do you think that it's, how irritated it's going to make you? So it's not that they're doing this on purpose. It's actually they're doing it because apathy is part of a brain injury when certain areas of the brain are damaged. So then it leads to this type of kind of function where they're not actually non-functional. And then that can lead to so much issues with family that these patients need to be treated, because this is a person who's doing nothing. And if it's 35-year-old person, and what, they're going to do nothing for the next 30 years. So there's a lot of push to try and kind of help these people. What about the effects on the family or the caregiver? So when I say family, I also mean caregivers. So as I talked about, people burn out. So I have spent a lot of time actually treating family members. So I start seeing the patient, and then I see the patient kind of comes in with the spouse or the other family members. And after some time, I realize that the families are falling apart. The spouse is extraordinarily depressed or extremely anxious. And then these are the only primary supports that the patient has. So I have to then treat the family to try and make sure that some of the supports that the patient has is still there, but also to make sure that the family member doesn't fall apart themselves, right? So we have to think about that as well. So effective management of these patients has to address all of these various points. Melissa, there's a couple of questions here. Do you want me to answer these questions, or do you want me to just kind of go ahead? I don't know, it says it was blinking here on me, so I wasn't sure whether you do anything with it.
Okay, so you might just be seeing the chat box. Yeah. Somebody just asked a question and I answered. She was wondering if the presentation was going to be online soon, and I just let her know that it was going to be on in the next couple of days.
Okay, so you will let me know if there's any questions that I need to answer, right?
Definitely, yes.
All right, okay. So what are some of the common issues? We have talked about this. You get the depression. I'm not going to go through all of this in detail unless you're interested, but then I can spend the next kind of 1 hour talking about this. But basically, if you damage the frontal lobes, as I mentioned, and the emotional parts of the brain, which is a little bit deeper, you can get depression. In the early stages of depression, when that means when patients get kind of depressed early in the injury, they actually often present with something called vegetative symptoms. Vegetative symptoms is problems with sleep, problems with appetite, problems with energy, problems with memory, with concentration. But if it's a late onset depression, which occurs, say, a year and a half later, they often now present with more of the psychological symptoms of feeling depressed, and they end up with somatic symptoms. Somatic symptoms is kind of symptoms where they end up having physical symptoms, like they end up with increased pain, or they end up with kind of problems with sleep, I mean, but sleep can also occur both. But they also end up with kind of just this sense of depression, this sense of anxiety. That's the psychological bit. But in the early stages, they often will just come and tell you, I'm having difficulty sleeping, right? And then you might have to address that. But it might actually be part of a depression that's going on. Now, what about anxiety disorders? Again, it's more common in the right hemisphere lesions, that's on the right side of the brain. And often these patients end up with something called a generalized anxiety disorder rather than something called panic attacks. A lot of patients do have panic attacks. What is panic attacks? Panic attacks are discrete periods of time where patients feel as if there's something really bad's going to happen. There's a sense of impending doom. And they end up feeling some physiological symptoms like their heart rate might be kind of doubling up. They feel as if they can't breathe. They got sweaty palms. They end up with butterflies in their stomach. Those are panic attacks. Now, both can occur. Both panic attacks can occur along with generalized anxiety disorder. Generalized anxiety disorder is where patients are anxious more often than not right through the day. Their anxiety doesn't necessarily get to the point of where they have panic attacks, but they are anxious about everything. I mean, so they don't end up doing a lot because they're also very, very anxious. And usually the generalized anxiety disorder, the anxiety disorders are more common actually in the mild ABI. In the more severe ABI, they don't seem to be as anxious, maybe because they don't recognize physiologically what's happening to them. But the patients who have concussions, patients who have mild ABIs often have more anxiety than the severe ones. You actually can get bipolar affective disorders. Bipolar affective disorders is the old classical manic depressive illness. Again, this is more, it can happen, but it's not as common, but it is happening. And the reason I put this up is because people sometimes ask me questions as to whether this is actually possible. Yes, it is possible, but for two reasons. One is that you can get a bipolar affective picture. When you say bipolar, all it means is that there's depression on one side and kind of manic or hypomania or kind of increased kind of inappropriate behaviors on the other side. That's all it means. The reason that these two things happen is, one, because of the brain injury itself as to where the brain might have been damaged, but it can also happen because of some of the treatments we give, some of the medications we give. So sometimes if you give them an antidepressant to try and make sure that they're less depressed, it often triggers them into getting into a bipolar, the other side. It doesn't necessarily mean that they have a bipolar affective disorder. It's almost like an iatrogenic or medication-related bipolar picture. It's not kind of primary bipolar affective disorder. And often this is also associated with anxiety. It's because I remember I mentioned that the generalized anxiety disorder occurs with right hemisphere lesion as well. And it's often associated with also the post-ABI epilepsy. It's more common in males and it's increased in patients with moderate to severe ABI. Now, personality disorders. This is something that we have to be careful that we don't diagnose too early, because to diagnose personality changes, you need a longitudinal point of view of the patient. So you need to see the patient a number of times to be able to say, okay, these people have an inappropriate way of dealing with things. These people have a maladaptive personality. And often this personality change happens as a result of the brain injury, but they might have had some kind of skewed personality types even from before the injury. So that's why when you do an assessment, you have to kind of spend a lot of time trying to understand who these people were even before the injury so that you can understand who they are after the injury. Because one of the things that happen in brain injuries is that patients are more of who they were. Essentially, that's the way to think about it. So not necessarily in a good way. I mean, I've had a few patients who actually have got better because they might have been very aggressive individuals, but now they are not. But most of the time, they are kind of more of who they were, but in a somewhat kind of not the ideal way. But the two personality disorders that you need to think about is something called borderline personality disorder and avoidant personality disorder. And then there's certain types that also is kind of common, like somebody who's depressed, but not actually depressed. It's called pseudo-depressed. And then pseudo-psychopathic, where in borderline personality disorder, for example, you can end up with some kind of vague psychotic symptoms as well. It doesn't mean that they've got schizophrenia or schizoaffective disorder. All it means is that they actually have they're called micropsychotic episodes. And again, frontal lobe damage. So frontal lobes, as you can probably see, is a very important part of our brain because it's the executive part of our brain. And as I mentioned, it increases in maladaptive personality. And then you get the psychotic disorder. I've usually already mentioned it, and usually it's paranoid. It's in the early post-ABI period. there's increase in patient with diffuse cerebral swelling and midline shifts. And usually it's fragmented delusions. What I mean by that is that it's not as if they turn around and say, okay, I know this person who's coming and kind of going to hurt me. They just say, I feel scared all the time. I feel as if somebody's going to hurt me. I don't know who it is. So it's like these are fragmented delusions. It's not fully formed, as it were. Then you get attention disorders. So people sometimes ask me, especially if it's a teenager or somebody like that who presents with ADHD type symptoms, is this ADD or ADHD that has always been there? It doesn't have to be. It's sometimes you also get something called secondary ADHD, which only happens in patients who have had a brain injury and they have no previous history of having had ADD type of symptoms. So it does exist. So there's secondary ADD, and it's described more in children, and it's no research is available in adults. And it's about 16 to 20% of patients seem to have this. And it's mostly they're inattentive. They don't actually become hyperactive, but they just don't have the attention. Mild TBI actually seems to be increased risk as well. Different areas of the brain can get damaged, and that leads to ADHD, but it's also comorbid. That means it can occur with the personality change, with oppositional defiant disorder, conduct disorders, and disruptive behavior disorders. And these are all the type of disorders that happen in children. So it's not necessarily associated with new onset depressive anxiety disorders. So is ADHD a factor? Yes, it can occur in a lot of patients. And this also needs to be treated because inattention often worsens memory. Already patients have memory issues because of brain injury. So if now they're paying less attention, their memory is going to get even worse. That's why they need to be treated. I do not know of any way of managing ADD without medications, right? I mean, you can try in children to kind of put boundaries and do all these other things. But at the end of the day, they often would need something like some medication, like a stimulant, to try and kind of get them to focus. And that's, again, a medication-related issue that we need to talk about. Attention disorders can often be worsened by all of the other things that happen with substance abuse, for example, with pain that people have. And again, if there is pain, we need to manage the pain with sleep disorders. And what I call iatrogenic syndromes, where we give medication that creates problems with attention and agitation. So I talked about, yeah.
My apologies, Dr. Seyone.
No worries.
I do have one question that relates to medications that just came up.
Yep.
It's kind of a lengthy one, but I'll read through it if they don't mind.
Sure.
So someone has asked, my husband, 51 years old, has a subarachnoid brain aneurysm in September 2020. His recovery has been complicated. Overall, he's recovered astonishingly well. Physically, he's almost 100%. He has chronic hydrocephalus and has a shunt. His executive functioning, processing, concentration, attention have been affected greatly. This affects his memory and wayfinding. The psychiatrist has suggested in the past ADD meds, which I think could be helpful. My husband has never been diagnosed with ADD, but he is definitely someone who has dealt with it over the years with strategies. Now, post-ABI, the coping mechanisms are not there, and his behaviors are very similar to my son, who is a teenager, who is on Vyvanase. Okay. Could that help my husband? He's currently on Keppra and donepezil.
Yes.
Is there a contraindication with ADD medications?
No, there isn't a contraindication with ADD medications except for somebody who might be psychotic. If somebody is psychotic to start off with, if you actually give them stimulants, they can actually become more psychotic. So if somebody isn't psychotic, then it's reasonably safe to give them ADD medications as long as you know what you're doing and how much to give. Vyvanse is a relatively good medication, and if your son actually is responding well to Vyvanse, there's a pretty decent chance that your husband also will respond to Vyvanse, because response to medications often run in families. So if there's already some level of kind of positive effect on Vyvanse, you can certainly try the Vyvanse on your husband as well. And you can start off at a small dose, and you find that, again, if he's able to focus, if he's able to kind of concentrate and kind of understand what is going on, you might find that his memory actually gets a little bit better, right? So I would certainly try it, but again, be careful that it's not just an ADD diagnosis, because sometimes ADD is part of a broader problem. The broader problem might be depression, because if he was high functioning before, he's now suddenly kind of has a lot of difficulty. He might be depressed, and that depression can also lead to inattention. It doesn't have to be ADD. Patients who are anxious because they are anxious about the fact that everything that they were able to do before would probably take 5 minutes for them to do. Now it's taking them 3 hours to do. So that makes people very anxious. And when you get very anxious, you actually pay less attention, right? Because when you pay attention, you actually get more anxious. So you have to be careful that you're not treating only one small aspect of it, whereas this is a kind of a broader problem. And then you sit and say, why isn't the Vyvanse working, right? It's not working fully because you're not actually addressing all of the various problems that you have, and you're only addressing one tiny component. So it has to be kind of be part of the bigger strategy about how to manage these patients. I hope that answered the question. Shall I proceed?
Thank you. There is one more question.
Yep.
This is from an anonymous person. He starts off with, is it usual for ADD symptoms and emotional issues to get much, much worse post-concussion, 16 months later now? And what to do? Never needed medication before, not sure what to use, getting depressed from symptoms and emotional issues. Tried Ritalin a few times, not good. Not sure if I should try Wellbutrin or Bifentin, my apology, Bifentin or something else.
Well, again, I mean, you're mentioning two different things. I mean, I heard two different things. One is the attention problem, but I also heard depression, right? And the same thing that I mentioned just a few minutes ago applies as well, because you can treat the attention deficit, but if you don't treat the depression, you're actually not going to get better. And certainly both of these conditions can occur in post-concussion, right? And in somebody who has concussion and then kind of a year later, they're still having the problems, then they might fall within those kind of very small percentage of people who don't recover from concussions as quickly. And sometimes it's the development of the depression, development of the attention problem that actually makes these concussions persist for a lot longer. So yes, you can treat the attention deficit. The difference between Ritalin and Bifentin is none, because both are methylphenidate. That's what it is. It's just a different formulation. That's all it is. So if you don't respond to Ritalin, the chances are you're not going to respond to Bifentin. The reason a lot of people choose Bifentin is because Bifentin comes in many different doses. So you can go at 5, 10, 15, 20, 25, 30, 35, that type of milligram doses. It's better in children because you might have to fine tune the doses. But in consider, for example, I mean, it comes in 18 milligrams, 36 milligrams, 54 milligrams. That's it. And there's a 27 milligrams as well. So it's a little bit more coarse. But if you don't respond to one, the chances you're not going to respond to the other one. So try a different class of medication. Try something along the line of dexedrine or dextroamphetamine, right? Which is completely different. It's still a stimulant, but it works differently. And Vyvanse falls within that class of medications. There's dexedrine, which is a quick-acting stimulant. Then there's Adderall XR, which is a slow-acting dexedrine. There is non-stimulant medications for ADHD like Statera, right? So you can try some of these different groups, and those might actually be more effective than trying something in just different names, but it's actually the same thing. But again, just remember that if there's also depression, you might still need to treat the depression as well. But in these type of patients, treat the depression with not something that sedates you, because that's going to make your attention in some ways worse, but something that also stimulates you a little bit. So it actually kind of works in conjunction with the stimulant to actually kind of make you feel a lot better. I hope that answered the question. This is where I can't see people, so I don't know whether I'm making sense or I'm answering the questions or not. So I'm just assuming that you're nodding your head, yes, I mean, I've answered at least some part of it.
Yes, the person actually responded with, it's a mild TBI, by the way, and he said, I heard Wellbutrin helps for both. And so
Wellbutrin can help, but Wellbutrin doesn't necessarily help ADHD. Wellbutrin helps depression, and it helps depression in certain groups of patients. It's not a panacea for everybody. It actually doesn't help for everybody. It helps certain people. If they're going to respond to it, they respond very well. Otherwise, in some people, they don't respond at all. So it doesn't do anything. But the reason that a lot of people try Wellbutrin first is one of the two medications that doesn't have any sexual side effects. Just about every other antidepressant has sexual side effects. So in young people, they often would start off with Wellbutrin because that actually will prevent one of the side effects from happening. And then if that doesn't work, then you try other things. Often Wellbutrin is used as an adjunctive medications with some other antidepressant to actually kind of work together. It doesn't usually work very well just by itself. All right, I think, how long do we have, Melissa? I'm not even sure. Is it an hour and a half?
So we have an hour and a half total, and it is now 7:05. So we have about 55 minutes.
All right. No, then I was just trying to figure out how much time I had and how quickly I should go through my slides. So, so we talked about sleep disorders. So a lot of patients, what happens is that after a brain injury, often would end up in kind of somewhat having a sedentary lifestyle because of maybe physical issues, maybe psychological issues, maybe depression, anxiety. And often these people use food as a solace. So what happens? They often put on weight. So patients might have put on 50 pounds since the brain injury. And so a lot of these patients develop obstructive sleep apnea, right? Some people have post-traumatic hypersomnia or narcolepsy or leg movements in sleep. So what happens? All of these people are now not sleeping. So if they're not sleeping, they get inattentive, right? So you can treat that attention till you're blue in the face, but if you haven't treated the sleep apnea, they're not going to get better, right? So a lot of these patients, you need to send them for a sleep study, make sure that they don't have obstructive sleep apnea, and then treat the obstructive sleep apnea if it exists. Because one of the other problems is that if somebody has an obstructive sleep apnea and they've already had a brain injury, their risk of having another stroke or something goes up quite significantly. So if you have had one brain injury, you don't want to have a second one. So if you have had one CVA or brain injury from a brain bleed, you don't want to have a second one because you have got obstructive sleep apnea syndrome and your blood pressure goes up in the middle of the night and you're blowing another aneurysm, right? So get that treated. So a lot of these patients have excessive daytime sleepiness, and you also get sleepy subjects being kind of more problematic in terms of managing them. And also the comparisons of sleep disordered and non-sleep disorder subjects, there's no relationship to the injury severity, cause of injury, or the presence of positive CT scan findings. So this is why I said most of these is because of the Yetrogenic, kind of people sit there and they eat and they kind of not as active, and that's what makes people put on weight. And that can happen in patients who've got a mild brain injury, but it can also happen in patients who've got severe brain injuries. Now, a lot of these patients also have something called iatrogenic sleep disorders, which is because of the medications we give them. A lot of medication we give makes people sleepy. And that sometimes is not kind of recognized, and then their patients still on the medication. For example, mirtazapine is an antidepressant that's often used by psychiatrists and other people to treat problems with their mood. But mirtazapine is one of the most sedating medications around, right? So you give them mirtazapine to manage manage their mood, but they're actually not spending the whole day sleeping. So you have to be careful that we actually kind of know what medications patients are on and how to treat that as well. So again, with the type of sleep problems, early post-injury patients have difficulty in initiating and maintaining sleep, while late post-injury patients have preponderance of excessive sleepiness during the daytime. Okay, so let's get into aggression. Aggression, it can occur in 35 to 96% of patients in various studies. That's a lot of patients. So that's 1 in 2. If it's 96%, it's almost every patient who has a brain injury can become aggressive. It can happen anywhere from less than 2 weeks to 4 to 6 weeks. It's because of post-traumatic amnesia. And you have heard of this patients going to the hospital with a brain injury, and often they're agitated and aggressive in the ambulance or in the emergency department because their brains are confused. Their brains are kind of unable to understand what's happening around them, so they end up kind of often becoming extremely agitated. There's also a condition called post-traumatic delirium, which leads to aggression as well. But aggression can also occur as a longer-term problem, like after the acute recovery phase. It could be days, weeks, months, years later. And so this is something that we need to think about as well. And often this is damage, again, to various parts of the brain, but I talked about the emotional part, and that's the limbic system, where the amygdala is an area which suppresses input from something called the hypothalamus, where memory is kind of also looked after. And then this kind of lack of connectedness from different parts of the brain often leads to patients being aggressive. The same with different other parts of the brain, like the temporal cortex or the frontal, but again, we get back to the frontal lobe. So as everybody can see, the frontal part of the brain, or the frontal lobe, is so important in so many different things. And that's why a lot of the problems that I have in my patients is all because of frontal lobe damage. And what people sometimes forget is that even if you have a primary injury somewhere else, the frontal lobe can still be damaged as well. Because remember, I talked about the twisting of the brain, the brain being able to move. So often you get damage to the frontal lobe, even if the primary injury is somewhere in the back of your brain, for example. So that's why a lot of these patients have all of these symptoms that I'm talking about, regardless of whether they had the damage on one side, both sides, or just on the kind of back of the brain, but they still can have a frontal lobe damage. And there are neurochemicals that often kind of lead to problems. So where the norepinephrine level goes up or serotonin level comes down. Now, when we give antidepressants, what are we doing? We are trying to increase the serotonin levels. That's what we're trying to do, because after a brain injury, the serotonin level goes down. In patients who become psychotic, their dopamine level goes up after a brain injury. So when we give medications, we're actually trying to block the dopamine, right? Acetylcholine is another medication that's very important in patients who have got dementia. And patients with brain injuries can develop ongoing memory issues down the road after about 20, 25 years. I think one of the questions that Melissa, you asked me was this particular person was on donazepam. Donazepam is an acetylcholine blocker, so it's often given in patients who have had brain injuries with the hope that it'll actually heal the brain. I don't particularly find it very helpful. I don't use it very much. It's more common and more effective in patients who've got significant dementia, because it kind of manages something called a catastrophic reaction. So it stops people from going from 0 to 100 and bypassing all the numbers in between. But in a brain injury in a younger person, it really doesn't seem to do too much other than just become one of the medication to be on. So what are the features of aggression we need to know about? It often is reactive, so it's triggered by some sort of stimuli, but in this particular case, the stimuli can be quite trivial. It doesn't have to be anything serious. It's not as if somebody goes and punches them in the face. It could be somebody like, for example, Troy's kind of son's making noise in a different room or something like that, and that might be enough to trigger somebody with a brain injury, right? So it's trivial stimuli can actually lead to severe reactions or unexpected reactions, right? It usually is non-reflective. It doesn't usually kind of involve planning, because the person is completely fine 1 minute and completely out of control the next minute. So they're gone from 0 to 100 and bypass all the numbers in between. It serves no purpose whatsoever. There's no goal orientation. It's explosive and it's periodic, and these things happen on a relatively regular basis. So the three behavioral syndromes we need to think about is something called the orbitofrontal syndrome, which is a behavioral excess. So it actually damages to the front part of the brain, at the bottom front part of the brain. And here you get the impulsivity, the hyperactivity, the lability, the psychomotor hyperactivity and aggression. All of these things can happen when you have this particular area of the brain damaged. And these patients then tend to be very impulsive and aggressive. Then you get the side part of the frontal lobe damaged. And here you get something called the slow syndrome. So patients become inattentive. They develop a poor judgment. They become something called perseveration, where they're constantly saying the same thing over and over and over and over again. They become passive. Their face doesn't show any emotion. It's all blunt. They can be disorganized and rigid and concrete. And so this is the dysexecutive syndrome that happens in patients. Now, please remember that each of these doesn't mean that if somebody has one, the other one doesn't happen. Often there's a combination of different aspects of these. And the third one is that, remember I mentioned the apathy. Apathy can be as part of a behavioral syndrome, because patients who are doing nothing often, in my opinion, and in all the patients I've seen, it actually irritates families a lot more than them being aggressive. Because when people are aggressive, at least there's some emotion involved. When the apathy, there's zero emotion, and it drives people nuts, right? So that itself creates all sorts of problems in terms of trying to we need to treat that. What about ABI in children? It does happen, and it's again consequence of abnormal development of personality, development of social cognition. All of these can then lead to effects of the brain injury. But you remember that the brain injury effects may not appear until they're in their teens or in their late kind of early adulthood. Because if they get a brain injury when they're 4 or 5 years old, often we have control of these kids for the next 10 years. We can prevent them from getting aggressive, because if they start having aggression, you just go put them in a bear hug and hold them, because they're small enough to be able to do that. But when they're 14, 15 years old, then it becomes extremely difficult to hold them down if they get aggressive, or if they get oppositional, or if they get depressed, or if they get anxious. And often these kids, they actually present as aggression. They present as oppositional behavior. They present as these kids are pain in the neck type of behaviors. That's what ends up happening to these kids, because they're uncontrolled, they're out of control. So also they're in the teenage years. So if you can imagine, I don't know how many of you have had teenagers, but if you can imagine the normal teenage dysfunction multiplied by 10, that's what a lot of these kids are. And these kids are the ones who end up getting into trouble because they're drinking, they're smoking, they're doing all sorts of things. And then it becomes more and more difficult to kind of manage them. But often they have normal neuropsychological testing them, because a lot of these things, it's a behavioral problems, but their cognition often is kind of relatively decent. So there's a condition called acquired sociopathy, which is it's a syndrome of social conduct disorders. They're normally normal individuals, but they're following damage to certain prefrontal regions of the brain. They have a damped emotional experience, emotional dysregulation, and you get disturbances in decision-making, goal-directed behavior, social behavior, insight. So they're not actually out to kind of cause problems, but they often get into problems. All right. So children, initially, as I mentioned, there's a lot of scaffolding going on initially when they were much younger. So normally in the near normal preschool and elementary years, and a lot of the problems start when they're in kind of high school or middle school even. And one of the another silent sequelae, I kind of touched on this. What about the impact on the family, on parents, siblings, extended family? There's financial burden, there's a physical burden, there's an emotional burden, and can affect caregiving roles, and lifelong support and ongoing family commitments get affected. What happens when parents get old and unable to care for a disabled child? What happens when services are unavailable or time limited? All of this can lead to issues with behavior as well, which needs to be managed. So finally, we get to talk a little bit about psychopharmacology, right? It has to be a team approach. It cannot be done by one person. So, I mean, I can't have a person come into my office and I write a prescription and send it off, and it never works, because I don't know whether they're taking their medications properly. I don't know whether they are kind of telling me everything for me to make a rational decision. So often it has to be a team approach. I need to talk to the therapist. I need to talk to their psychologist. I need to talk to the parents. I need to talk to their brothers and sisters. The more information you have, the better you are in trying to decide what needs to be done. Patients is at the center of the coordinated care, but it needs to be coordinated. You need to be able to kind of talk to different people and try and figure out what's necessary. And what works for one individual doesn't necessarily work for another individual. So it has to be individualized. It has to be kind of the jacket has to be made for that particular individual. You can't have a off the rack jacket and they expect it to fit everybody. All right. So ABI can lead to psychotic problems, can lead to medical problems, cognitive problems, medication issues. It can lead to substance use, can lead to financial issues, work issues, family issues, premorbid factors, compensation issues, and psychosocial issues. And you need to address all of that. If you don't address all of these, the patient is not going to get better, right? So some of these are, so the ones in red are often managed with medications. The ones in the kind of orange are basically need the team in the community to address a lot of these other issues as well. Because you can address depression with medications. But if the person doesn't have a sense of focus, sense of purpose in their lives, and they're actually not able to work because work was very important to them, you're not going to kind of treat their depression very well. So if they got significantly dysfunctional family because everybody is falling apart, you can treat the patient with anxiety medications, but as soon as they go home, their problems start happening again because the family is falling apart. Or if they're using substances kind of heavily, medications don't work very well when they're kind of up to their gills in kind of alcohol. right? So you need to kind of think about all of these various issues to be able to kind of treat the patients more effectively. So the initial management of these patients are try and understand who this person is. Who is the person? Who am I dealing with? So their medical issues, their educational issues, their social issues, and then try and understand who they were before the accident as well. Are they competent, in fact, to kind of give you treatment decisions? What are their daily living skills are like? What are their cognitive abilities, their social skills, their behavioral problems? What are their family and social relationships? Any recreational problems, any employment interests and abilities? You try and understand all of this, and then you can decide how you want to manage the patient from a psychopharmacological perspective. Now, I'm not going to talk a lot about the community-based management. I'm just going to focus a little bit on this. So how do you manage aggression and agitation? One is psychopharmacology, but that by itself is also not enough. You need to teach them alternative acceptable behavior. Teach them how to develop contingencies. And then with medication, some of these other things might address aggression. What about if they're disinhibited or sexually inappropriate? You need to kind of figure out a way of giving them some acceptable outlets. Recreational workshop. You can't actually just kind of give them medication to take away their completely sexual drive. It doesn't work. We can't castrate people. So we can give them medication that might decrease it, but we need to find a way for them to express some of their needs in a different way. What about if they're passive? Address the fatigue, because that might be the reason for them being fatigued. Reinforce social groups, get them trying kind of involved in different activities if possible, and then think about medications. What about attentional disorders? Again, you can try and do instructions, reinforcements, and prompts, and then think about medications. Memory deficits, you try and kind of, this is where psychologists come in because they are better at this than I am. You can do kind of daily planners and all of this. And then if the memory deficit is part of attentional disorders or depression, then you kind of think about medications. If they're depressed, psychotic, anxious, often you need to give them medications first before you can do some of the other things. If they've got family problems, again, social skills training, you might need to do family therapy in these patients. If they've got financial issues, financial assistance, housing issues, get some housing for them. So because if you can't address everything with medications, you also need to be able to address other things without medications or in combination with medications. So the common groups or the common medication that are often used is antidepressants. Antidepressants are used not just for depression, but also used for anxiety. It's used for behavior. It's used for sleep difficulties. Antidepressants can be used for many different types of psychotic problems, or actually other problems as well, even medical problems that happen. Somebody who is, for example, has problems with stiffness or kind of spasticity, sometimes antidepressants are used to try and address that as well. So there's something called SSRI, which is selective serotonin reuptake inhibitors, and the most common ones are, the old ones are Paxil, Prozac, and Luvox, but the newer ones, there are many of them. And these again work through the serotonergic pathway. Then there's something called SNRI, which is serotonin norepinephrine reuptake inhibitors, where the most common ones are venlafaxine XR, that's often given. There's Pristique, right? And then there's a newer one called Fetsima. Then there's other ones that are relatively uncommon because they actually have more side effects, so we don't actually get there, but these are the two most common ones. Anxiolytics, a lot of people get very worried about using benzos because everybody worries that they're going to get hooked on the benzos. In my experience, I've had patients of mine on years on benzos, and as long as you don't mess around with the dose too much and they actually it's doing something, patients stay on the same dose for years. And if that gives them a quality of life, what's wrong with it? Right? People worry about that somebody's going to get hooked on it. Do you worry about getting hooked on medications you take for hypertension or high blood pressure? You don't, because you're going to be on it for the rest of your life. So what difference does it make if you're if you need it? The same way with the benzodiazepine. If that is actually working better than any other medication for managing anxiety, what's wrong with staying on it? Right? It's not as if tomorrow the anxiety is going to go away and then you need to worry about taking you off the benzodiazepine. So again, they sometimes kind of unnecessary worry, even by healthcare providers, even by psychiatrists, that these people are going to get kind of hooked on them. If it by getting hooked on them, if it leads to significant liver problems or kidney problems, then I can understand it. But no, the risk of all of that with benzos are about the same as every other medication, right? Then there's the neuroleptics to treat the psychosis. So we talked about, and there are different types of neuroleptics. There's things that are high potency, low potency, mid potency. There's atypical, and normally these days we start off with the atypical. Atypical things like Abilify, Luvox, sorry, not Luvox, Latuda, Zeldox. So all these are atypical ones which came on the market in the last 10 years or so, and they are much better tolerated, so much less side effects. Then the sedative hypnotics that are often used for sleep, like Zopiclone. There's a newer one called Sublinox. There's another one called Lunesta. Then again, benzodiazepines are often used as sedative hypnotics as well. Then there's anticonvulsants, things like Valproex, Topamax. Often these are used to try and control behavior, not as an anticonvulsant, but as a behavior control. So this is not just because they got bipolar affective disorder, but some people just aren't having behavior, the impulsivity, the poor judgment. If you put them on a little bit of Valproex, it actually settles them down. Then we talked about stimulants, the methylphenidate, the atomoxetine. Atomoxetine actually is Statera. And the methylphenidate is Ritalin, right, or Bifentin. Both are the same thing. So again, just remember that medications are not one medication for one person. Sometimes patients need a combination of medications for it to be effective. So lower doses of 2 or 3 medications sometimes is better than very high doses of one medication. Because when you give very high doses of one medication, often these patients have a lot of side effects. But if you can kind of combine the thing properly, then the patients actually do well. So a lot of times when I have residents and when I have kind of teaching other people, it's not that they don't know how to, I mean, they don't know about medication. They often know about medication. They can probably tell me all the different side effects of all the different medications. But what they need to learn is when do you start, what do you start, and how do you combine that? And that is what is not in textbooks, right? And this is something that you're not going to learn by kind of reading a textbook, because that is going to be something that's going to come with experience, with having done this for a very long time. And you know how to start and when to start and what do you start with and what is most important to treat first and second. And then so there's priorities. So, yeah.
Sorry, there's a few more questions. Do you want me to bring them up now, or would you like me to wait till the end of the presentation?
I think I'm quite close to finishing it. So why don't we just finish it?
Okay, let's hold it off.
Yeah.
Thank you.
So the common side effects of medications are based on what medication they're getting. So the groups of medications, like for example, the SSRI has certain side effects that the SNRI doesn't have. SNRI has certain side effects that the SSRI doesn't have. Because one of the problems with, say, venlafaxine is that it sometimes gets difficult for patients to come off it because it leads to certain side effects. So depending on the group of medication or the dose of medication that people are getting, you can have certain types of side effects. The route of administration is important. If they're getting tablets because they are compliant in taking them, or they're getting injections because they need once a month injection, because otherwise they won't take their medication. So you get different types of side effects. So you need to think about that. Who is the patient we are giving these medications to? Is there other medication that the patient is getting where there's drug interaction? So a lot of these patients might be on medications to manage their neurological condition or manage some other kind of medical issue they have, like diabetes or high blood pressure. And we need to know whether the medication that we give them is going to interact badly with some of the other patients, because we can give them medications to manage their depression, but because they're already on a medication that makes them feel a bit sleepy, now when you give a medication that manages depression but also has sleepiness as a side effect, now those two combine to make the patient non-functional because they're too sleepy most of the day. So you need to be able to know that. Then there's unknown factors. I've had patients where I give them a sedation to calm them down, and they actually have exactly the opposite effect, where they're getting very, very aggressive and agitated. So these are paradoxical reactions. These are reactions which we don't know why it happens in some people. They have a different mechanism of how they are kind of tolerating the medication, so they end up having sometimes the opposite reaction. So the main side effects is neuroleptics have something called an acute dystonic reaction, which is the most kind of dangerous one, but that if it's going to happen, it's going to happen within the first 2 or 3 days of starting the medication. This is where everything goes into spasm. So you get, it's a muscle spasm. So you can have problems with even breathing because it's your muscles around your neck goes into spasm. It's a simple thing to treat, but first of all, you need to identify the treatment. Actually is an injection of something called benztropine, and it actually makes things go away within a couple of minutes. But if you don't identify it, it can actually become quite dangerous. Then akathisia is an agitation that people can have on medication. So you give them medication to treat some of the agitation, and they in fact get more agitated. And so that might be part of the medication as well. Then there is something called extrapyramidal symptoms, which is the physical, the muscle manifestation of some of these neuroleptics. And then tardive dyskinesia, which everybody worries about, is a long-term side effect. So if somebody's been on medication for about 5 to 10 years, they can actually get something called tardive dyskinesia, where it's a movement disorder that is created by the medication. And if you treat it early, then it actually goes away. If you don't treat it early, it can actually persist for quite a long time. There are other common things like patients have gastrointestinal upset. They might have problem with sleep, either less or more. They can have postural instability. They can have falls. They can have incontinence. Again, people don't seem to think about sexual dysfunction, but if you're giving medications to a 25-year-old and the person can't function sexually, you might as well kind of say, okay, this person is not going to take his medication. You think he's taking it, but it's never going to happen, right? So this is why you think, oh, why is the person not getting better? Yeah, the person is not getting better because the person is never taking it, because this has a certain side effect. So no, again, if you don't ask for it, you're not going to find out what the answer is. So this is where kind of you need to take your shiners and put it on a shelf somewhere and kind of talk about, ask the right questions to find out what the problem is. Then the stimulants can cause akathisia, which is the same thing as the neuroleptics, but it can also cause irritability and aggression. And stimulants does have a potential for abuse, because patients sometimes kind of take more and more than they should. And this is where, if you put somebody on stimulants, you need to monitor them. You need to see them in follow-up. And you need to know that they're not going from one pharmacy to another pharmacy. It happens to me occasionally where I will get 2 pharmacies calling me about the same patient, because the patient has been to 2 pharmacies wanting a prescription refill. But because I have records, I can turn around and tell them, no, I'm not. And if a patient does that to me, they will actually not get the stimulant from either one of the pharmacies, right? So you have to be careful with that. So in acute aggression, you give an antipsychotic, atypical antipsychotic like risperidone. There's other newer ones like Abilify. There's olanzapine, which actually works on people's mood, and it actually calms them down. It also actually makes them sleepy a little bit. But again, you have to think about over-sedation. And olanzapine, for example, can cause a lot of weight gain as well. So we have to be careful with that. Some people on some of these medications start drooling. A lot of these medications, psychotic medications, decrease seizure thresholds. So if patients are having seizures and they're controlled on medications, you need to realize that when you give some of these medications, that the seizures can actually kind of start up again, because their seizure threshold drops. So you have to kind of make sure that you manage the anticonvulsants as well. Clonazepam is, I use clonazepam quite frequently, because it actually kind of takes away some of the anxiety that people have. But again, you have to worry about over-sedation, postural instability, disturbed coordination. Again, a lot of these things are theoretical side effects. It doesn't always happen if you're careful about how you give medications. And as I said, I give lower doses, but give them 2 or 3 different medications, so they don't end up with massive doses of one medication, which causes then all these side effects. And chronic aggression is managed, as I mentioned earlier on. You can use anticonvulsants to manage this aggression. So you can use carbamazepine, something like valproic acid, bone marrow. But again, you have to be careful about bone marrow suppression. Some of these can be hepatotoxic, which is a toxicity towards the liver. Then there's lithium is often used. Again, you can get toxicity for neurotoxicity, which is kind of nervous toxicity, and then confusion can happen. Then there's certain beta blockers. Beta blockers are basically medications that are used to manage blood pressure, but it actually kind of works very well to try and manage anxiety in patients as well. So you can use things like propranolol, atenolol. Most of them actually are tolerated quite well. Some people might have something called orthostatic hypotension, which is blood pressure that doesn't adjust as quickly when people go from lying down to standing or sitting down to standing. So they end up feeling a bit dizzy for a few seconds. That can happen with beta blockers, but otherwise it's relatively well tolerated. Some of the new antidepressants like Zoloft, Effexor, Wellbutrin. Again, you have to worry about headache. Oh yeah, one of the things that people often complain about, some of these antidepressants cause severe sweating, especially the venlafaxine or Effexor XR can cause severe sweating to the point where people say that I had to change my shirt 3 times a day. I'm kind of my bed sheets are drenched every night. I feel so hot even if it's minus 20 degrees outside, right? And that all is because of Effexor, which all goes away when the effects are stopped. Benzodiazepine can cause sedation. Antipsychotics, you try and look at the newer medications like risperidone or olanzapine. There's Abilify, Zeldox, Latuda. All of these are the newer ones that can be given. What about medical marijuana? It can be helpful. It's dependent on what medical marijuana you get. So it can be helpful in managing a few things. It can be helpful in managing anxiety. It can be helpful in managing sleep, right? It's not usually helpful in making people happy, right? I mean, even though people argue with me and say, oh, if I take a lot of THC, I'm happy. But yes, you might be happy, but if you take a lot of THC after brain injury, you might also be psychotic. So you got to be careful because you have a much higher chance of getting psychotic on THC after a brain injury than if you didn't have a brain injury. But a little bit of CBD with a little THC touch of it often can be helpful in improving patients' sleep as well as kind of their anxiety. But you have to be careful with how you select these patients, and you have to remember that a lot of these patients might turn around and say, I use 1 gram per day, but they're often using 3 grams per day. And in those patients, I mean, you have to worry about psychosis. So one other thing, we also have to look for the psychopathology in the caregivers and help them as much as possible. And I'm trying to emphasize this because this is often not emphasized enough. And if we don't emphasize them, sometimes caregivers feel as if there's no help for them and they burn out, and that creates a lot of problems, not just for themselves, but for the rest of the family as well as the community as well. Now, we can also use therapies, behavior therapy, cognitive therapy, supportive and individual therapies. But again, these are in conjunction with some of the medications. And sometimes if the medications work very well, you can actually keep those stable and then do some of these other therapies to try and make the patient even better. Like, for example, you can use a cognitive therapy to manage the anxiety even after medications, which is controlling the anxiety to an extent, but there's still a little bit of anxiety left. Instead of increasing medications, you can actually give them a little bit of cognitive therapy on top of it. And then supportive and individual therapy, family therapy, you can use a lot of these different therapies. And that is it. Thank you.
Thank you, Dr. Seyone. I do have a few questions that have come up from some of our members. So I'm just gonna, okay. So the first one was going back to, and I forgive my pronunciation, going back to mirtazapine. Is there a better alternative? I was prescribed this medication for mood and depression. I sleep well with it at night, but I still tire during the day. Could that be fatigue or is it the medication? It's hard to tell.
I'm not going to be very, I'm not going to be very popular with whoever is prescribing the mirtazapine because I personally don't like mirtazapine very much. For exactly the same reason you're talking about. It actually causes, yes, it makes people sleep, but it also causes this sedation during the daytime. And if somebody's already got fatigue during the daytime, this actually makes things worse. 2, it's not a very good antidepressant. It actually doesn't work very well as an antidepressant. So it actually, I use it more as a sedation, more as a way of managing people's sleep than as an antidepressant. So if I want to give them an antidepressant, I actually will give them something like venlafaxine or desvenlafaxine or one of these other ones. And then if they're having problem with sleep, I might give a very small dose of mirtazapine just to help them sleep. But I wouldn't depend on mirtazapine by itself to actually manage their depression, plus their sleep, plus whatever else is going on, because it's not as good.
Thank you. Okay, so the next question is, it starts off with the member is thanking you for a very useful presentation. And he says, I am a chronic ABI survivor from Klebsiella pneumonia meningitis, diagnosed in summer of 2018. I have 2 specific queries. 1, among other things, I have issues with my sleep and memory. Is there a particular therapy to help with LT memory and near-term memory? Is it likely to improve with time, or should I learn to live with this mental disorder? The second question is, for family members providing care, are there available resources that they can use? What disorders should they look out for? And is it advisable to let the ABI patient actively look for volunteer post-COVID, given the memory issues have rendered them unlikely to return to work?
All right, Melissa, now you're expecting me to remember things I'm probably not going to remember. So I'll ask you about the second question.
Sure.
Right? To answer the first question, memory is a funny thing. I mean, it's the maximum amount of recovery following a brain injury occurs in the first 2 to 3 years. So if your injury was in 2018, I mean, it's now 2021, the chances are that a lot of recovery has already happened. So would there still be ongoing recovery? Yes, then always. I mean, the brain continues to heal, so there's some recovery even 3rd, 4th, 5th years later. But the most amount of recovery is in the first 2 to 3 years. So the rest of it, so it might happen 1% here or 2% there. So it kind of goes up. So is your memory suddenly going to become better tomorrow because somehow the brain has healed more? No, I doubt it, right? So that's a bit of a bad news for you. But is there strategies for learning memory? I mean, learning to live with that memory? Yes. I mean, there is the memory clinic at Baycrest, for example. They actually teach you strategies on how best to manage memory loss. So they tell you how can you use a cell phone, how can you use schedulers, how can you use different types of aids to actually manage memory, right? And that's the same thing that we do with some of the brain injury organizations. So I don't know whether BIST does that, but I know things like Mind Forward with Cheers, they have actually memory programs where they teach people how to kind of compensate for whatever memory loss they have. So it's not that you are kind of, you're not directly improving their memory, but in a sense, indirectly improving their memory because they don't forget as much because now they have got strategies for dealing with that memory. I mean, what I always keep telling people that if something is not in my schedule, I don't remember it, right? But because if things are in my schedule, I don't forget anything, right? So I make sure I'm become very rigid and very kind of careful about making sure that I put everything in my schedule because otherwise I forget. So it's not that I have problems with memory, but it's also that because things are in my schedule, I kind of present as kind of not forgetful because I remember what to do, right? Because it's my schedule. I mean, my schedule goes hourly or whatever. And that basically tells me, okay, I need to do this today. Like, for example, today I had to also fix something else. I mean, like call up, I think, Electra or something like that. So I put that in my schedule, call them, right? Because it needed to be fixed. So, but what people think is that if I had very good memory before the accident, why shouldn't I have the same type of memory and why should I learn all these new strategies? No, you have a problem. And also memory difficulties can also happen with just normal aging, right? And that's what people also forget. If your injury was 15 years ago, you're also 15 years older, and therefore your memory is going to be a little bit worse. So you tend to keep schedules or learn new strategies. I mean, I had a very, very good memory when I was in my 20s, but I'm not in my 20s anymore, right? So I have to compensate for whatever memory loss I have as well. And that's why you learn strategies. And so you learn to put things into your phone. And so the rigidity comes in with how good you are at putting things into a phone, how good you are at putting things into a computer, how good you are at looking at it. It's pointless putting things into a schedule if you're never going to look at it. But you train yourself. Every morning when I get up, I'm going to look at my schedule to know what I'm going to be doing for the rest of the day. I'm going to keep looking at my schedule every hour to make sure that I'm not forgetting something. But again, that has to become almost like normal for you, right? So those are the memory strategies. But again, these are things that can be taught through agencies like Baycrest Memory Clinic, through Mind Forward, through Cheers, through York's Brain Injury Services, through BICA, through, I think even BIST probably has some sort of training, or at least they can direct you to people, right? What was your second question, Melissa? I said my memory isn't good, so.
The second part is for family members providing care. What are the available resources that they can use? What disorders should they look out for? And is it advisable to let the ABI patient actively look to volunteer post-COVID, given their memory issues have rendered them unlikely to return to work?
I mean, I'll answer the second part, first. So yes, there's no reason why they can't volunteer as long as they've got the vaccination and the place that they're going to has already been vaccinated and it's safe, right? As long as it's been deemed safe for both the place where you're going to volunteer and for yourself, there's no reason for you not to volunteer. And volunteering actually keeps you busy, keeps you motivated, keeps you happy. So, it's not something just because it's post-COVID that you're never going to volunteer again for the next 5 years. I would suspect that you're not going to be able to volunteer much for the rest of the year, maybe for another 6 months. But hopefully by next year, when most of the population is vaccinated, we'll be able to get back to some semblance of normal. And at that time, by all means, go back to volunteering. Now, in terms of supports for family, most of the agencies that I work with, and I think most of the agencies in Ontario, and actually even outside Ontario, are having family support groups now. So they run groups where something like what the two Melissas are doing right now in terms of kind of having this kind of webinar. They actually have people coming in. I mean, and these are family members for education purposes, for kind of support. So the people come and talk to each other. So they learn from one person as to what another person can do, or what has worked for and what hasn't worked. So these are family support groups that happen. Then there are other type of assessments. For example, I will get referred family members for an assessment because the family members falling apart. So I might have to actually treat them. And to answer your question as to what are the common conditions that we treat, the most common is depression, right? Because you have to remember that family members have certain expectations and hopes for you as a family member, right? If you're a son or daughter, they want you to succeed. If you're a spouse, they wanted their life to be something, they had a vision of where their life was going. But all of this was taken away by the brain injury. And so a lot of these people feel completely overwhelmed and they get very, very depressed. And often this needs to be addressed. So the depression and anxiety is the most common problems that happen in family members.
I'm just going to jump in here. Sorry. Thank you, Dr. Seyone. Sorry, Melissa. I always have a hard time not talking. I just wanted to jump in with two comments. So one, BIS does run a peer caregiver support group. It's the last Wednesday of every month. Right now, obviously it's virtual. It was in real life before COVID and will be again, but you can visit the website, www.bis.ca, or email us at info@bis.ca and we can get folks registered for that. BIS also loves volunteers and we're always grateful to have volunteers. And once again, when we're kind of back and up and running and in the office, whoever was interested in volunteering, if you also want to reach out to us at info@bis.ca. We do accept volunteers for a mentoring program. So that entails mentoring new survivors of ABI and sharing your experience with them and helping them kind of go through the event, as well as volunteers for our program. So please be sure to reach out to us. And back to you, Melissa.
Thank you. I was actually just going to say that. So thank you so much. And to just add on to the last bit that Melissa was talking about, the peer support program, if you are interested in becoming a mentor or a partner, feel free to email me at peersupport@bis.ca and I can help you find someone to match up with. So now, oh, my screen just changed. I'm going to jump to the next question. That's okay. We just jump to the next question. Where was it? So someone has asked, when you say damage that is measured by symptoms and common with post-concussion of mild TBI, or has to be major or show on does that have to be major or show on an MRI or other scan?
Mild traumatic brain injury is never seen on a scan. Or not never, I mean, most likely not seen on a scan. And that includes CT scans, that includes MRIs, sometimes even PET scans, SPECT scans, Muga scans. I mean, it doesn't matter. Often these scans are not sensitive enough to pick up mild brain injury because mild brain injury is not a structural damage as much as more as a chemical damage. So it's more at an intracellular level. And our scans are not fine enough yet to be able to pick up these things. I'm sure some of you have heard about something called chronic traumatic encephalopathy. Now that is where it's a pathological diagnosis. When people die, they actually take the brain, they kind of put slices and look under a microscope, and that actually shows certain changes in somebody who has a brain injury. And a lot of these have been kind of looked at in sports injuries. So people who are football players, people who played rugby and all these other things. So, but again, we can't do a microscope analysis on somebody who's living. So often these patients with minor brain injuries or minimal brain injuries or concussions, they often will not show up on scans. That doesn't necessarily mean that they don't have problems. It just means that you don't see any kind of definitive evidence of the injury itself. So often the diagnosis of a post-traumatic sequelae is often based on clinical evidence. And evidence from other people that this person is completely different, and you try and kind of collate all of this and come up and say, yes, this person did have a brain injury.
Thank you. I'm going to combine this person's two questions, just because they're kind of on the same subject.
Yep.
The member has asked, I was using, again, apologize for my mispronunciation. I was using Vigmond, vilazodone, name medications in Canada, but
can you run that?
Sorry, vilazodone.
Okay, it's not available in Canada.
Oh, okay. But I couldn't afford it as it doesn't convert. So something similar to that. This medication helped me, but it affected my IBS. Do you know about this medication? The second part of her question is, can CBD also be used with antidepressants like Vigmond?
Okay, I don't know enough about Vigmond because especially if it's a treatment for irritable bowel syndrome, I'm not a gastroenterologist, so I don't know of all the medications that's available. I don't know enough about what these medications do in terms of irritable bowel syndrome. So my apologies, but I can't comment too much on that. In terms of cannabis, yes, in some people, the cannabis seems to help irritable bowel as well, right? So it helps, but again, because there is one school of thought that says that irritable bowel gets worse when people are anxious, right? So if you can manage that anxiety a little bit better, and if the cannabis manages that anxiety, the irritable bowel syndromes sometimes get better as well. Now, can it be given with Vigmond? I don't really know. I don't know what the drug interactions are because I don't know this particular medication very well, so I can't really comment on it. That's something that you might want to ask your gastroenterologist to see whether there is an issue. But I would suspect that the cannabis should, as long as you stay with more of the CBD and not the THC, I would suspect that it actually will work relatively okay with it.
Perfect. The next one is, again, I'm going to combine this person's so we can go back and split them if we need to. Could you kindly comment and recommend effective natural supplements for common ABI TBI symptoms? And she's thanking you. She says, also deeply grateful for your presentation and thank you in advance for potentially answering my question. The second part of her question is, for example, are there supplement suggestions for increasing concentration, decreasing headaches, memory, getting to sleep, decreasing anxiety, balancing mood, and combating fatigue?
I'm going to become very unpopular right now, right? The reason I'm going to become very unpopular is that I'm not a firm believer in supplements, right? The reason is that maybe part of it is the type of practice I have because all my patients have severe problems. You can take supplements till you're blue in the face, and when you have severe depression, when you have severe anxiety, when you have severe cognitive issues, it doesn't do enough, right? It's like St. John's wort. St. John's wort is often used to manage depression, right? But it manages depression if the depression is on a scale of 1 to 10, 10 being about the worst depression you can have and 1 being perfectly normal, it manages depression about 1 or 2, right? Anything above 2, it doesn't do much, right? The same way with supplements. If you have minor problems in terms of your cognition, if you have minor problems in terms of anxiety, if you have minor problems in terms of sleep, yes, some of these kind of supplements may help because it makes you generally healthier, right? But if you go above, say, a 4 or 5 in terms of severity of illness, it's not going to do anything. I mean, it's like expecting somebody who's malnourished, who has severe protein deficiency, kind of you're giving a little bit of protein, about kind of 1/10 of what the person needs, and expecting that person to get better. It's not going to happen, right? So as people spend fortunes on supplements, I mean, they get protein powders that are this big in bottles. I mean, they get all sorts of different tablets, and they're taking more supplements than what I can give them. But the reason that they're still coming to me is because they're still having problems because the supplements haven't helped them. So they're already taking the supplement before they come to see me. So why am I going to give them even more supplements? Because the assumption is that it's not working very well. Otherwise, they won't see me. So to answer your question, as I said, I might not be very popular. I mean, with people who are taking a lot of supplements. To me, supplements are adjunct. It sometimes might help. I mean, people talk about ginkgo biloba and all these things. Is it going to work but primarily for somebody with severe memory problems? No. If you do all of the other strategies for memory issues, if you try and give them stimulants to address their ADHD problems, if you give them, if you treat their depression, if you treat their anxiety, then if you give them a little bit of supplements, it might actually help, because it's a lot of things are under control and there's a little bit of problems, and the supplements might help. But you can't kind of expect to just use the supplements and kind of with all of these things present and then say the supplements are going to work. It's unrealistic. So do I prescribe supplements? No. Would I turn on and say stop the supplements? No. But if I start somebody on a medication and they say, can I also take a supplement with it? I said, no, wait till let's see what the medication does. Let's get an idea as to whether you are getting better or not. Then if necessary, then we'll worry about a supplement. Because if you do well on this without the supplements, why do you need the supplement? Does that answer your question?
I think so. I think it was a great question, and thank you so much for clarifying some of that, because I think that supplements are so, like you said, popular at the moment. You know what I mean? And rather than spending money somewhere that may not be helpful, over popularity, I think that was great. Thank you so much.
You're welcome.
The next question is, are there any suggestions for treating PTSD? And what about trazodone for sleep and anxiety or panic attacks on a low dose?
I'll answer the second question first. Trazodone is actually a pretty decent medication in certain people. I mean, it works in some people, it doesn't work in other people. So, I mean, even today I prescribe trazodone at 25 milligrams for one of my patients. So it's about half of a 50 milligram tablet. It depends again on how bad the problem is. So if the sleep is kind of somewhat disrupted, not that completely out of control, trazodone works very well, and it's actually tolerated very well, and most people actually respond to it quite relatively well. It's only when you start giving higher and higher doses of trazodone that you might get into other issues, because basically it gives you dry mouth, it gives you constipation, it gives you all these other side effects, which then becomes problematic because patients now feel uncomfortable on it. So at the lower doses, trazodone is perfectly fine. Now, in terms of PTSD is a complex field. I mean, because PTSD can occur in variety of degrees of severity, if you want to call it, right? And PTSD, is it because of the brain injury? Is it because of the accident? Is it because of something that happened to them? We don't know yet. But can they have PTSD symptomatology after a brain injury? Of course they can, right? Especially if they had a brain injury because they've fallen down 20 flights of stairs. Yeah, they're going to have PTSD and they remember that, right? But often there's some controversy about PTSD in the sense that they say, how can you have PTSD if you don't remember the accident? Yes, you can, because you still spent 6 months in ICU. So you can have PTSD. It's not just the event of the accident itself. It's what happened to you after the accident. Or you have an accident and somebody has to amputate your leg or something. Yes, you're going to have PTSD, right? But the way PTSD presents is the classical thing is they've got hyperarousal where they feel a lot more anxious. Then there's nightmares that you have. Then there's kind of avoidance. Those are the three main components of PTSD. The avoidance, we can do some, I mean, it's not treated usually with medications, but it's treated with kind of re-exposure to certain types of issues. The hyperarousal is often increased anxiety, so which might need medications, but the nightmares become often more problematic to manage. So there are some medications, there's one medication that often people are using now to manage that, and that's called prazosin, right? If you go to a PTSD clinic, I mean, especially in somebody who's been abused or something, prazosin is it's a medication that's often used. It's again a blood pressure medication, but it also seems to take away nightmares. So often they will give the prazosin at nighttime just to see whether that nightmares go away. So it actually takes away one of the symptoms of PTSD. But again, you remember that PTSD is not just to manage with medications. Often that they also need significant amount of counseling, right? So they need to see somebody who has some experience with dealing with PTSD and then try and kind of counsel them through it, because it also depends on the type of PTSD you have, right? Because not everybody can manage PTSD as a result of sexual abuse. So you need specialized counselors. PTSD as a result of a brain injury, you might still need counselors, but somebody who knows something about brain injuries and what patients go through, right? So again, you need an expertise in that sense. It's not just medications.
Perfect, thank you. Okay, so we have about 1 more minute. I'm going to take a risk, and I'm going to give you 1 more question. And then to all of our members watching, unfortunately, that's going to be all the time we have for tonight. The final question is asking about hormones and how, okay, what about how hormones can play a part in mood changes, lability? Do you test for hormone levels before prescribing antidepressants or mood stabilizing medications? I've heard that TBIs can cause dysregulation in hormone levels, and my understanding is that it can affect your moods, depression, and anxieties.
Yeah. Some of the hormone levels go down. It's like, for example, testosterone can go down in patients who, following a brain injury, and they often kind of can lead to depression, right? So in these type of patients, you often would want to increase their testosterone levels, right? But it's a relatively minor percentage of people who have depression as a result of testosterone levels. It's a relatively minor percentage of people who have other hormonal abnormalities that then lead to all of the psychotic symptoms. So you're looking at about maybe 2% of people who have hormonal changes after a brain injury that leads to psychotic problems. The other 98% of the people actually have all of the other things that we talked about today. So do I kind of, as a routine, do hormonal assessments? No, I don't, right? Because it's difficult to do hormonal assessments. It's not all labs will do it. It needs specialized kind of labs to be able to find out what the different hormonal levels are. And also, I mean, like, even if you find that the person has a little bit lower on the low normal of testosterone, what are you going to do? Are you going to give them testosterone? Because you have to be careful about giving them testosterone, because it can also make them very aggressive. If they're already aggressive, that's going to get worse, right? So if they're kind of, say low in, I don't know, estrogen, what are you going to do with it, right? I mean, is that leading to the depression? Nobody knows, right? So, I mean, and I'm not an expert on prescribing estrogen. So, I mean, I can send them to a gynecologist to try and prescribe some estrogen, but I still have to manage all of the other conditions that they have. And just giving them estrogen, I don't think is going to manage all these other conditions. So it might, again, the hormonal assessment might play a role, but it's generally a secondary role in the sense that you try some things. If that doesn't work, then you're now looking for other types of things that actually might work. So in that situation, then hormonal assays and everything else become important. Or if the person has some symptoms, something that indicates that they got hormonal problems. For example, I mean, like somebody has like characteristics of low estrogen levels or low testosterone levels. Yeah, then you think about doing testosterone levels. For example, if it's a man and there's no reason for them to have any sexual difficulties, then I should think about doing a testosterone level to make sure that that's not low, because that might be the one that's causing the problem. So you need some level of indication to be able to kind of say, okay, let's focus on this, and then let's go there. Answer the question?
I think so, yes. Thank you so much, Dr. Seyone, for coming in tonight. And your presentation was absolutely incredible. There's all kinds of thank yous coming into the chats. People have really enjoyed it. They're talking about how informative it was, how helpful it was to all of them, and how excellent it was that you were able to answer all of their questions essentially throughout the evening. Thank you.
My pleasure. It's been a pleasure. I wish everybody all the best, and have a nice evening.
Thank you. Bye. And thank you again to the PIA for helping us to put together an incredible ABI Info Series this year. And thank you to everybody who has participated and all of the members for coming in to participate every night or every Monday night.
Yes, and we look forward to doing this again. Thank you, everybody. Thank you so much.
Thank you. All the best.
Thank you.
Bye.
Thank you.
Bye. Oh, God. Night.
Thank you, Melissa.